Welcome back, every Bendy Body, to the Bendy Bodies Podcast with your host and founder, Dr. Linda Bluestein, the Hypermobility MD. I am so excited to chat today with my very dear friend and colleague, Dr. Ilene Ruhoy. She and I are good friends, so you never know where this conversation is going to go, but I guarantee you that it will be interesting. Dr. Ruhoy is a board-certified neurologist with a PhD in environmental toxicology. She completed a fellowship in integrative medicine with Dr. Andrew Weil at the University of Arizona. Her interests include connective tissue disorders such as Ehlers-Danlos syndromes, autoimmune neurologic disorders, neuromuscular disorders, intracranial vascular and pressure disorders, infection-associated neurologic conditions such as long COVID, ME/CFS, and PANS/PANDAS, traumatic and inflammatory brain injury, mitochondrial disease, neurodegeneration, and exposure illness. Dr. Ruhoy has a private concierge practice in Seattle, Washington, and has become a well-sought-after speaker on the role of connective tissue in neurologic disease. I am so excited about this conversation. Dr. Ruhoy and I spoke about brain fog and cognitive dysfunction quite a few episodes ago, back in episode 90, and we'll link that in the show notes. Finally, we're going to talk today about treatment of cognitive dysfunction, and I'm sure we're going to dig into all kinds of other topics as well. Cognitive problems are so common with the triad: Mast Cell Activation Syndrome, dysautonomia, and the Ehlers-Danlos Syndrome's hypermobility spectrum disorders. So this is a really important conversation. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. All right. So excited to finally chat with Dr. Ruhoy again. We've been trying to do this for such a long time, and I can't believe we're finally going to get to chat.
I agree. I'm very excited to be here. Thank you for inviting me again.
Of course, of course. So we talked, well, I didn't want to think about how long ago this was, but we had an episode about brain fog or cognitive dysfunction, and I want to make sure that people go and check that episode out, which was episode 90. That was such a great conversation with Dr. Ruhoy and so much in-depth information that we really thought we needed to come back and have another conversation about treatments of brain fog and also talk about your upcoming book, of course.
Yes.
So when it comes to cognitive dysfunction, and we're going to use that term and or brain fog, is that pretty fair to use those interchangeably, do you think? Or
I think it depends upon the patient. Sometimes it's not synonymous, but sometimes it is. And I often say that brain fog is a patient experience. So very commonly when patients report brain fog, I will ask them further questions as to what that means. And I will go down the list of even concerns of cognitive impairment kind of questions like, do you get lost in familiar places? Do you forget familiar names? Do you forget what the conversation is about? Do you have loss of time or loss of awareness? So just to sort of make sure that there is truly no cognitive impairment in sort of a more classic sense that they're experiencing, but usually not. Usually it's this brain fog, which is sort of like thinking through a fog, basically. So a very sluggish kind of feeling. And most importantly, they feel fatigued from intense cognitive work. So being asked to learn something new or being asked to follow a chapter in a book or a television show, even watching a screen, can create a real sense of just, that their brain is just no longer functioning and they have to close their eyes in a dark room and rest.
And does that seem to help, taking a break like that? Okay.
It does, actually. I mean, it doesn't completely resolve the symptom itself because, of course, that's one of their underlying symptoms of whatever their illness is. And so it's very easily triggered. There's a very low threshold for those kinds of symptoms to reoccur, but they will get some respite for sure if they're allowed to just sort of lie in a dark room without any sensory stimuli, close their eyes. I mean, so one of the problems when there is brain fog and any kind of cognitive challenge is that the brain is very sensitive to sensory stimuli, to external stimuli. So things like noise and things like light and sound and, patients can't be in a very crowded room, for example. And if there's a lot of ambient noise, they can't hear the person that's talking to them or they are triggered by the person that's talking to them. And it's usually got nothing to do with the person themselves, but rather the sound of their voice, And so, and if there's a lot of fragrances in the air, I mean, I have patients who tell me they can't go to malls any longer because the stores have a lot of fragrance that are sprayed into the air. And so that can be very bothersome to them. So the brain just becomes very sensitive, very hypersensitive to just sensory stimuli from the environment.
That's really interesting because I'm thinking also about are patients that have hyperacusia or sensitivity to sounds, and I happen to be one of those people. And I'm going to share something a little more personal. My husband's chewing. Like there are times where it drives me nuts, and it's like I love him dearly, and he doesn't listen to the podcast, so it's okay to share this, I think.
I totally understand.
Yeah. But it's fascinating because there was a French study that looked at the prevalence of different things in people that had, conditions that look like Ehlers-Danlos syndromes, and then they looked at other musculoskeletal clinics, and that hyperacusia was one of the things that showed up on that list. So it's really interesting.
For sure. I do think that connective tissue disorders in general are a risk factor for a lot of these things, and so I think it's not surprising to me to learn that a lot of these clinics and other groups that see a lot of patients with particular concerns of like hyperacusia, but is that they see a lot of connective tissue disorder patients because it does seem to be a risk factor for these symptoms.
Mm-hmm. And I'm glad you mentioned fatigue right off the bat, because I know before I opened my clinic, I really did not realize how many people would really be struggling with severe fatigue. And with a lot of my patients, I'm finding that their pain has gotten a lot better, but their fatigue really persists. So I'm really excited to get some ideas from you for managing that. So in terms of medications that can help with cognitive dysfunction, brain fog, fatigue, things like that, what are some things that come to mind?
So I usually start with, the usual suspects that I think a lot of doctors do with regards to just mast cell management. And, usually my triad that I start most patients on, if not all, LDN, ketotifen, and cromolyn, just to stabilize the mast cells. I personally, and I probably am in the minority of this opinion, but don't think that these symptoms are related to, or at least not primarily related to, a histamine concern. So I don't really find a whole lot of benefit from the antihistamines in my patient population, which I recognize is skewed, right? I mean, who's going to see a neurologist if they don't really need to? So that's probably the reason why. But so I do a lot of mast cell stabilization, and I do a lot of immunotherapy kind of approaches, because I see this as an immune dysregulation problem. A lot of these illnesses are what we consider post-infectious illnesses, and obviously long COVID, and as is ME/CFS, has long been thought to be a post-infectious illness, or post-exposure illness, as I like to call it, because it's not only just infection that we're exposed to, but so while I see a very strong mast cell component, I don't see it as necessarily a primary histamine problem. So in fact, most of the symptoms are, cannot be related to classic histamine kind of responses. So I find stabilizing the mast cells and regulating the immune system is way more effective than the antihistamine approach.
And when you're talking about regulating the immune system, are you talking about IVIG or other things? Okay.
So immunomodulators, and I definitely start with the more broad spectrum, as I refer to them, which is IVIG. I do a lot of plasmapheresis. And again, because these are, there's a lot of targeted immunotherapies available these days, the JAK-STAT inhibitors, the tyrosine kinase inhibitors, and so on. And then I like the old guard still because we just know a lot about them, but they do suppress the immune system fairly significantly. And so I try to avoid them for the most part, but I will go to them if we have to, meaning like the cyclophosphamide, the CellCept, the methotrexate, the azathioprine. There's so much data on them that I think doctors are well armed with what to look for. And in terms of surveillance of labs and even side effects, we've used them for decades now. But the targeted immune therapies, I think, have great promise, and I'm finding great use of them when I need to go there. But I really get a lot of traction for patients with IVIG and plasmapheresis. I find them to be a lot safer, with a lot less toxicity concerns, and easier to do. It's not easy in the sense of insurance approval, of course, but just easier to just get done for the patient.
And tell me more about the plasmapheresis. Like who's a good candidate for that, and how does that work in terms of the number of times that you might need to do it, and some of the details of that?
So apheresis is sort of an umbrella term, and there's lots of different types of machines, and some machines have particular filters where they filter out a particular parameter that's in the plasma. We use a centrifugation system, so we basically take out we take out the blood, it's centrifuged, then it's separated, and we remove the plasma, and we don't return it. So it's not filtered and returned like some of the other machines will do. There's no exchange as it used to be. It still is called in some clinical scenarios where it's a plasma exchange. And so you get plasma from like the blood bank, and there's an exchange of plasma. But we just do where we remove the plasma, and the volume is replaced with albumin, which is the natural protein of the body. And albumin itself has anti-inflammatory properties. So, so we infuse the albumin, and the body eventually just renews the plasma component. And so what we find is that removing the plasma does a lot of great things. So as you probably know, it's an FDA-approved treatment for autoimmune diseases. We use it for several different autoimmune neurological disorders, myasthenia gravis just being one of them. So it's a treatment that's well known to remove autoantibodies that circulate in the plasma. But the plasma also has other things that is removed by the centrifugation process, including a lot of the mast cell mediators, a lot of the inflammatory mediators, circulating viral RNA. It removes, obviously, the autoantibodies. It also removes extracellular ATP, which can happen from mitochondrial failure. And I'm finding more and more that that's a component of the fatigue that a lot of long COVID and ME/CFS patients will experience. In fact, I do muscle biopsies, and I have basically seen 100% of them be abnormal at this point. It's too few of an N to say definitively that it's always the case, but it's sort of an exciting development that I think, deserves further looking into. But so when the mitochondria start to fail, the ATP is extruded from the cell. And obviously, as we all know, the powerhouse of the cell, mitochondria. But so intracellular ATP is critical for the functioning of the cell, but extracellular ATP is actually toxic to the cell. So the fact that it's got a very short half-life. So it's not like it's accumulating at, crazy amounts, but regardless, it's in the plasma. And so it's being removed along with plasmapheresis. And so I think that's one of the reasons why patients do so well with plasmapheresis. With regards to how many sessions you need, so first of all, it's not covered by insurance, which is a problem because these are obviously off-label indications, despite the fact that it's an FDA-approved treatment. So it's not cheap because it's a 3-hour treatment. It's a big machine, requires a technically competent nurse. And so it's an expensive treatment to administer, and so it's an expensive treatment to get. So it's not covered by insurance. So that's an obstacle that I wish I can fix tomorrow, but I can't, and I'm thinking of ways to do so. But and then it's 6 treatments is the initial protocol. So it's 2 a week for 3 weeks, basically. And that's sort of the recommended protocol to start the plasmapheresis. And then some patients, in 6 months' time feel like their symptoms are recurring. And so they come back for what we refer to as sort of this maintenance or booster session, which is usually just 2. And then, they seem to do well thereafter. In fact, half of them don't need that maintenance/booster session.
Oh, really?
They seem to just continue to do well. And largely because after the 6 sessions, I tend to, continue with immunotherapy. So immunosupport. Sometimes I'll keep them on IVIG at lower dosages for a period of time. Other times I'll, work on their mast cells as I had been from the very beginning. But now the medications seem to have more efficacy because we've sort of cleaned out what the medications might have to contend with when they're taken. Because the things that were in the body floating in the plasma that were presumably causing the problem are no longer present. And so it seems that it certainly makes IVIG work a lot faster. That I have seen over and over and over again because I do a lot of IVIG. And usually if there's a few sessions, it doesn't have to be 6 actually. If you're going to do IVIG, if you have a few sessions of plasmapheresis beforehand, the IVIG seems to be a lot more efficacious and work at a lot faster rate. Oftentimes you have to wait months before you know if it's helpful at all. With plasmapheresis first, then you don't have to necessarily wait months. You usually know within 1 to 2 months if IVIG has been helpful. And it's generally helpful. So I think it just helps also make medications work better because, again, we're just sort of, I hate the word cleansing because it just sort of, there's connotations to that word, but we really are cleansing the plasma, cleaning the body of the unhealthy plasma products. And so I think that's a key to initiation of successful treatment, in my opinion.
Mm-hmm. And I'm glad you circled back to what happens after the sessions are over, because that's what I was thinking as well. When the body, it makes more plasma, wouldn't it just create more of the things that were causing the problem in the first place. The plasma, or the part that separates from the red cells when you spin it down, right? Just so for people who don't know what plasma is. So, and then in terms of those medications that you mentioned, so it's the ketotifen and the cromolyn and the low-dose naltrexone. So there's some people probably that with that regimen alone are doing sufficiently better, I take it?
Oh, yes, absolutely.
Yeah.
Yeah. I mean, it's amazing. Some patients really do well with those medications, but some patients, and I think largely because of the mast cell activity, are very sensitive to these medications. And I know, we've talked about on the mastermind list and the group that we're both part of, the role of the excipients, and that definitely plays a role. But I have found that that a lot of patients who have had issues with the excipients or the preservatives or the fillers or what may be in the medication itself, or even the supplements that they take, that is less of a problem after plasmapheresis. So, and I think it's because we're removing a lot of those mast cell mediators. And it's important to note that, I think that a lot of those mediators, there's 1,200 mediators of those mast cells. So it's well beyond histamine, but a lot of those mediators serve to just provoke more mast cell activity. And so I think removing those mediators just sort of gives those mast cells a break, basically like a rest for a period of time. Obviously not, permanently, but for a period of time. And so if we can then go in after the plasmapheresis and then further manage those mast cells as well as we can, I think it's giving the patients a fighting chance. And it's certainly what we see here in the clinic. It is, and so that is ultimately our goal, right? Is to sort of just counteract all of this inflammatory response that the body is sort of encountering, that is sort of creating this altered physiology that is causing their symptoms.
Right. And I think so many people are familiar with histamine being one of the mast cell mediators, and maybe tryptase, and maybe some of the other cytokines or proteases or things like that, but not 1,200 different
exactly.
things, right? It's kind of crazy.
And just
to think
so you know,
about.
I mean, you can't test for all 1,200, right? So that's the problem. And
right.
so you can test for a select few, and then we get focused on those select few. And I think, and there's no other way around it, of course, because we haven't developed assays for all the other mediators, So I think that we tend to focus on those select few, which sometimes actually works well in the patient's interest, but oftentimes it doesn't.
Mm-hmm. And histamine itself, how does that affect the brain?
So there are histaminergic neurons, and there are H3 receptors that are unique to the central nervous system, believe it or not. So, there isn't enough research to say definitively how it affects the brain. We know that the H3 has high affinity for histamine. We know that those receptors can modulate the level of histamine that is released in the brain. And so, the antihistamines, we know also lower migraine threshold and lower seizure threshold, right? So I think histamine has a role has a neuroprotective role. I know this is sacrilegious.
Wait, histamine does something good?
Right. It's not always a foe. It can be a friend, and I think that's an important point. Obviously, with mast cell activation syndrome or disorder, histamine can be a big foe. It can certainly be an enemy, right? So, because that's excessive then, right? That's what but clearly, I mean, mast cells are meant to be our friend, meant to protect us. So hence, there's a good role for histamine, right? So, and I think that's been lost in a lot of the talk about mast cell activation syndrome, is that what really was the nature's intended role for histamine, right? And the fact there are histaminergic neurons and there are specific histamine receptors of the brain that are not found elsewhere. They're certainly not counteracted by all of the antihistamines that are on the over-the-counter market these days. So there is something more, I think, that we should talk about and we should explore and we should research. And I often think about all of the unopposed histamine floating around because everyone's on the H1, H2 blockers, so I often wonder, what is that doing? And those H3 they have such high affinity for histamine that they just are gobbling it up. And so, how is it changing the function of those receptors, and how is it changing the function of histamine in the brain? And, and why are there so many neurologic manifestations, for example, of EDS patients with MCAS, and so I think that the answer lies within that. And I have yet to know a definitive answer, but I plan on figuring it out. That's
If
my
anyone's
goal.
if anyone's gonna figure it out, it's gonna be you. That's for sure. And in terms of the H3 receptors, we don't have a way to we don't have any medications yet for H3 antihistamines.
Well, there are some medications actually.
Okay.
One is not available in this country. It's beta histine or something like that. But then there's also Wakix pitosalant, which is an H3 inverse agonist. So it does work on the H3, but it's got a different kind of receptor property. And I've actually tried to use it for my patient population. I cannot, it's actually indicated for narcolepsy. I cannot get it approved if there isn't a diagnosis of narcolepsy. And the few times that a patient paid out of pocket for it, one, it's expensive, but two, I didn't see a great response, enough for me to feel like it was worthy of the price that they were paying, kind of thing. So, and to be fair, I don't think I let them try it long enough when I think about the physiology, but I'm definitely considering sort of revisiting that question.
Mm-hmm. Okay. And speaking of medications and masterminds, we get into such interesting conversations in there sometimes, and there's so much more talk nowadays about the GLP-1 receptor agonist, right? Like semaglutide, which goes by Wegovy or Ozempic. And I read someplace that could be helpful for intracranial hypertension.
Yeah.
And do you have any thoughts about that class of medications? Of course, I think somebody shared today something about it. It can help with 60 different conditions, but also can make these 19 conditions worse. was the title of the article. So of course we don't have time to go into all of that.
Yeah, but and I didn't read it today, so I don't know.
Yeah. And I didn't read through the whole article, but I thought that was really really interesting. So, any thoughts though about those medications? Because I know intracranial hypertension or high pressure inside the head is definitely something that you see in your patients as well, right? High and low.
Yeah. Yes, and to be fair, I haven't used the GLP-1s to treat that just yet, but I will say that I've used GLP-1s for mast cell activation. For excessive mast cell activity. I've used it for fatigue. I think there's something to the glucose regulation, the glucose metabolism regulation of the glucagon-like peptides that really do seem to help a lot of patient symptoms. And then I think about how that even speaks to the mitochondria, right? If we think about glucose and its regulation and how it's fed to the mitochondria, which loves that glucose molecule for the electron transport chain activity, then, I think that there's a connection there. It's just interesting to me that it has so many great properties, yet we don't talk about, how mitochondria are in every cell, right, of every organ. And so, and it's interesting that it might treat elevated intracranial pressure, which, like I said, I haven't tried for, but I'm certainly willing to try it because a lot of my patients have refractory intracranial hypertension and don't tolerate the classic meds like acetazolamide or even because, it's a sulfa drug. And so then you can't even do the topiramate. Sometimes I've been going to zonisamide for those patients, which they tend to tolerate a little bit better if they don't tolerate the acetazolamide. But it's not nearly as effective. So I've been trying different things. So yeah, I'm going to try the GLP-1s now.
Yeah, that's just something that I came across the other day. And in terms of medications and or supplements that can make cognitive problems or brain fog worse, are there certain things that come to mind?
So I'm not a big fan of supplements, and I think everyone knows this about me. I think my patients are just too sick to waste their money on supplements. It's just not going to move the needle enough for them. I think supplements have a supportive role, and there will be a time in their recovery trajectory where I say, okay, let's support this process and support this momentum, and let's add some of these supplements. But early on, initially, I don't think it's useful. And in fact, when patients come to me with a list of the supplements they're taking, I usually say I cross most of them off. I think that there's a couple of them, having said all that, there's a couple of them that I'm a big fan of. I like the quercetin and I like the luteolin for the mast cells. I think that they're very effective. I like things like palmitoyl ethanolamide, otherwise known as PEA, which really helps pain. It really helps inflammation. I like NAC, N-acetylcysteine, it's a precursor of glutathione, which is really what I like. But it's glutathione itself, unless it's liposomal, though I'm still not sure, but it's not that bioavailable. So NAC is a precursor of glutathione, so I like that. And so other than that, I mean, to be honest, and magnesium, I think we're all magnesium deficient. So I think those are the only supplements that I would support early on in treatment plans. I think supplements are a waste of money for the most part. I'm going to say there's a lot of sacrilegious things these days.
That's okay. I love it. I think it's very important because, of course, it's just become the Wild West, right?
It is.
And it's so frustrating because I'm sure you get this too. You have people coming in and they've gone so many different places and they've, in some cases, tried some really crazy things.
I have to look stuff up half the time. They'll say, "What do you think about this? That I was told to do this. What do you think?" And I have to Google it. I'm like, I don't know. No, it is true. It is like the Wild West is a perfect way of describing it, and it scares me for these patients, because there's the potential of making things worse for sure.
Right.
Obviously, you don't want that to happen to them, so you try to make, reasonable decisions, and you also try not to make them feel badly that they've been doing this for so long, right? It's I think for me, I'm like a bleeding heart. Like I always feel badly about everything. Like, oh, I'm sorry. So I try very hard to say, like, listen, I don't think this has been harming you, but I think it's a waste of your money, and I don't think it's helping. But it is the Wild West, and that's a little bit scary to me. And those things aren't even regulated. So, and there was a study a long time ago, and I have to pull it out, but where they took a bottle of the same supplement and they put it through like a spectroscopy machine, and they found that every capsule had a different amount of the compound that was labeled outside the body. In fact, some of the capsules had none of it.
Wow.
So you don't really even know what you're buying sometimes. And, so you have to go with respected brands, and that can take time for people to vet out, like, what is their, extraction technology and their methodology. I mean, way back when, long time ago, I took a course in herbal formulations just to learn more, because I was really, I did a whole integrative medicine fellowship, and I was really into using plants as medicine, and I really am into herbal formulations, and I like a lot of them. But part of the courses that we went to, like where they make these formulations, these tinctures. And so I learned a lot about extraction technology, which is why I say those terms like they're nothing to me, extraction technology.
Right.
But so I learned a lot about it. And while I don't remember a lot of the details because it was, a long time ago, but it did make me realize that the methodology does matter. Right. But I mean, obviously in science and medicine, we know that. And that's why in papers, the methodology it has to be included. Right. So because it does matter. It really does matter. So anyway, that's my opinion is.
Yeah. And I feel like, people with the triad or the pentad or, whatever number you want to, septad, whatever you want to include in terms of these overlapping conditions, they're such a vulnerable group because they're, desperate for help, and they're such a poor match for our current medical culture where you're in and out of the appointment in 5 minutes. You're in and out of the appointment in longer than 5 minutes, but you're with the doctor for about 5 minutes probably. Right. And you have way too many concerns to really get those addressed well. So then you hear about these other things, and they probably seem quite attractive. And a lot of them are very good. A lot of the charlatans are very good at, promising cures. And, it's really, really tough. Speaking of, I read something recently about plasmalogen. Are you familiar with that? Is that?
So lots of people have asked me about plasmalogens, and I did a quick look. And to be honest, I don't yet have a formal opinion. I have this long list. So my book is like list of things that I have to do deep dives on, just because I want to be sure that I guide patients appropriately. It's on my list.
Okay. Sounds good.
Yeah.
That sounds like another episode.
We should do an episode on plasmalogens.
That would be great. We're going to take a quick break. And when we come back, we are going to talk about your book. This episode of the Bendy Bodies Podcast is brought to you by EDS Guardians, paying it forward in the Ehlers-Danlos Syndrome's community, patient to patient for the common good. I am proud to serve on the inaugural board of directors for EDS Guardians, a small charity with a big mission and a big heart. Now seeking donors, volunteers, and partners. Patient advocacy and support programs available now. Travel grants launching in 2025. Learn more, shop for a cause at their swag store, and join the revolution at edsguardians.org. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, we're back with Dr. Ilene Ruhoy, who is an incredible neurologist and environmental toxicologist. She had her PhD that she got in environmental toxicology, and she has recently written a book, which I am so eager to hear more about. I was very fortunate to get to preview it, but I would love to hear what's going on with the book, when it's coming out, and those kind of things.
Yeah, I'm real excited. So it's called Invisible No More. It does tackle like long COVID, ME/CFS, and all of the septad diagnoses as best as it can. It's a real exciting project for me. It's my first book. I've never authored a book myself. It took a long time to write. So a lot of it was written over 2 years ago, believe it or not. So a part of me worries about how even relevant some of what I say in it is, but I think there's still relevance regardless, because chronic illness is chronic illness. And it comes out June 17th, 2025, though it is available for pre-order right now. And it starts with my story, which, I was a patient 10 years ago, and no one would listen to me. And I went to lots of doctors because I wasn't feeling well and I couldn't figure out what was wrong. And I went to people that I knew who knew me, and I thought that they would take me seriously, but I was wrong. And, in the end, they saw me first as female and second as a neurologist. And so nobody took me seriously. And I just needed an MRI, and no one would order it for me because, they didn't want to feed into my hysteria. And they told me that I knew too much, that I was stressed out, that I was anxious, that I missed my family, and I always often wonder if they would have said that to a man.
Right.
But I spent almost a year suffering, and things just kept getting worse. So, and my neuro exam was normal. I mean, it's, unfortunately, the diagnosis itself was different and easy to find, which I'll get to, but it was the same story where my exam was normal, my labs were normal, and so, but symptoms just kept getting worse, and no one was taking me seriously. And so finally, I got to a point where I couldn't get out of bed in the morning. And so I went to an internist, and I just cried. And I said, please order me an MRI. And her words were, when a neurologist asks for an MRI of the brain, you order an MRI of the brain. And so she did. And then when I came out of the MRI machine, the tech said, go right to the ER. The radiologist called, you need to go to the ER. And that's sort of where it all began. But I'm so angry because that almost year that I wasted trying to get someone to believe me really did have consequences. And that's sort of what I go into in the book. But, so I, and then when I sort of was done with my journey, and I opened up a private practice, I realized I just can't allow that to happen to other people. And while clearly my patient population, their diagnosis is not obvious on an MRI of the brain, I know what it's like not to be believed. I know what it's like not to be taken seriously. And I know what it's like to be told oh, you're just anxious. You just have anxiety. And so I never do that to patients, and I meet them where they are, and I believe what they tell me unless they give me reason not to, which really has maybe happened once in my entire career. So I find that when you believe a patient, things just get done. There's a therapeutic relationship that automatically occurs. And then you go on that journey with that patient of trying to figure out what's going on. And that's the part I love, and to be honest, I was a little burnt out on medicine, but this has sort of renewed my passion for it, right? I love neurology again. I love medicine again. I love working with patients again. And so I think this is why there's such burnout, because doctors aren't given the time to really connect with their patients any longer. And I know a lot of patients like to complain about doctors, and I try to defend them because I think the healthcare system is broken.
Yes.
Doctors that work in hospitals are only given 20 minutes to see a patient, and you're not going to get anything done in 20 minutes. I mean, I can't. And and the patient won't feel seen in 20 minutes. So, I think that's the problem, not the doctors. I think it's the system that just breaks them down. And then, when they don't have enough time to really deal with patients, then they just sort of decide like, okay, well, I'll just do the bare minimum, which is like, what's your symptom? Here's a prescription, right? And so, or you're just anxious, don't worry about it. Just go home, go have fun, go to the movies, So I think, so I knew what it was like not to be felt. And I never want anyone to feel that way. And if I was treated that way as a neurologist, I could, I feel bad for these patients. How do they navigate the system? Yeah. So that's why I do what I do. So I start up in my book sort of telling that story and how that led me to sort of the place where I am today, which I never thought I would be. I mean, who knew a neurologist, was going to be a connective tissue disorder specialist?
Right. Yeah.
I mean, seriously, but that's where it led me, because it's such a connective tissue disorders are such risk factors for everything else that can go wrong with the body, that, that's what creates, I think, complex presentations. And so they weren't getting answers from anyone else, and they just came to see me, and I just decided that I would believe this and see if I could help figure it out. And it turns out that a lot of them had connective tissue compromise. So I dived deep into that. And then here I am, 10 years later.
Yeah. And I feel, yeah, exactly. And I feel so badly for physicians who, come out of training, they have a massive amount of debt, and they have to take a job in a traditional model where I have so many, physician friends working in those kind of models. And like you said, 20 minutes for new patients, 10 minutes for, returning patients. And it's insane. And I mean, some people, they'll see like 40 people in a day, which maybe that math doesn't quite work out. But I do know definitely that there's people that see that many patients in a day.
Oh, and absolutely.
Yeah. 40,
Could you
50.
imagine?
Yeah. No, I can't. I mean, I'm sure your caseload is like mine, where you could never see that many people with these complex conditions in a day. Never. There's no way. You can't serve them properly. So, no. But when you have this massive amount of debt and you have, a young family or whatever, you often find yourself in those kinds of jobs, and it's terrible because it's not satisfying. It's not good for the patient. It's not good for, your self-esteem or for feeding your sense of meaning. It's really problematic.
I completely agree. Everything that you just said is spot on. That's exactly what happens. And it's such a shame. And it's a shame. And what's even more of a shame is that the insurance companies have made us doctors look like we're the tools. Right. We're the problem. We're the bad guys. And the hospital administrators have done the same. So somehow the doctors are the scapegoats for everything that's wrong with the healthcare system. Right. But we're the only ones trying to make it better for patients. So the whole thing is so broken. And, it's very saddening when you think about it.
It really is. And we're the ones adding value.
Yes.
The insurance company, where's their value? I mean, there
is no value.
Yeah, there isn't. And the hospitals have such powerful lobbies, and it's amazing. I just saw a statistic the other day, and I wish I could remember it more specifically, but it was something like the number of healthcare administrators over the past decade or something. I'll try to find the statistic and or the article and put it in the show notes, but had gone up by, I don't know, 30-fold or 10-fold or 15-fold, some dramatic number, whereas the number of physicians had gone up, 5% or something. It was just normal growth, whereas the number of administrators had gone up dramatically. And it's just, And obviously that money has to come from somewhere. So that's the other thing is, for every dollar that's spent on healthcare, a huge amount of that is going to insurance companies and administrators and things like that, not actual care.
And what people don't have to recognize, and I'm sure that they do, but it's important to point out that the only billable people in the healthcare system are doctors, right? So it's on our backs that we pay the administrators and that we get the insurance companies their money. And that's not fair, because, we're the ones that are micromanaged by the hospital administrators, by the RVUs and how many patients you're seeing and what you're ordering or not ordering, that kind of stuff. And so it's just so upside down.
Yeah. Yeah. And that's why so many practices, I mean, there used to be lots of private practices, right? But so many of them have gotten absorbed and bought out by hospitals because the overhead became so high. I mean, that's what happened with my husband's group. Their overhead was really low when he first started it. They had basically 1-to-1 for every doctor. There was an administrator. So like 3 doctors and 3 administrators. And by the time he left, there were like 7 doctors and like 45 administrative people.
Oh my God.
Yeah, well, because, right, there's the person that has to get the prior auth for the CT scan or the MRI or whatever. So they had this massive amount of people, and exactly what you just said, it's the doctors who are creating the billable hours. And so their overhead went from like 20% to 60% over the course of his career. So
wow,
that just was not sustainable.
Nope, it's not. And it's also what's behind a lot of the mergers that are happening amongst the hospital systems.
Mm-hmm, right.
And some of the mergers are not in the patient's best interest. I mean, my husband's group was bought by a very religious hospital organization. And so they did away with like gender affirming care and, transition medicine and abortion care and trans rights care, whatever the hospitals were supporting, they did away with all of that. So there's a lot of pain in the community because of that particular merger. But then there's also, further economic downfall on the doctors. Because now there's a lot of administrators, as with your husband's experience, there's a lot of administrators who are looking at what the doctors are billing and what they're not billing and what they're doing and not doing. And, the other thing that I don't understand is that doctors by definition are supposedly an intelligent lot, right? Like we went through school, we took 1 million exams. I feel like it was 1 million. I was always taking an exam. Right, exactly. And yet we're not allowed to even like use our brains or give opinions or help to decide on structure and system. And like, I feel like we're just sort of relegated to an exam room and just told to see patients all day, every day. And I just don't understand the misuse of what are presumably not only intelligent people, but caring and compassionate people. Why else did we become doctors, I mean, when I graduated college, a lot of my friends, I'm from New York, so a lot of my friends went to Wall Street and made, millions of dollars by the time that they were like 30. And I was, in residency, it's a very different life that you choose,
Yes.
So it's like, why did we do this if we're not going to be given, the respect and the valor that we deserve, in my opinion,
Yeah. And I think that in terms of what's changed over time, and I want to talk about how your practice has changed over time, but I know for sure, seeing this in my husband's practice, that when he first started his first job, well, actually, this was his only job as a urologist, they valued quality. And the hospitals were so happy that he was there doing surgery. And by the end, they just wanted somebody there seeing patients. They really didn't care about quality anymore. So that's also really upsetting. And I know your practice has evolved a lot. So I'd love to hear about that.
Yeah, my practice has evolved. And some days I feel really badly about it because I recognize that my choice to not engage with those insurance criminals has, consequence on patients who don't have disposable income. But there was no other way I could keep my practice alive. I couldn't pay my staff. I couldn't pay my utilities. And so I had to choose not to bill insurance. And over the years, it was clear to me that I made the right decision because I also spend a lot of time with patients. And so, as you know, insurance companies don't bill you for extra time spent with patients. And so a lot of my time was just being non-reimbursed. And that is not a good business model. And any business person would tell you that. And I would have business people as patients who would say like, how are you making this go? And I'm like, I'm not. I'm failing. And so I realized I had to make different business decisions. And so that was one of the decisions. And so since that time, though, I continue to not bill insurance, of course. And I continue to, and obviously I offered, treatment options, but it's non-bill, I don't bill insurance for them. And it does create I feel badly about it on a lot of days, especially with patients who I know are struggling and suffering. And and they will tell me that they've saved up for an appointment, which, breaks my heart. But, I know that there's going to be further changes in the future to my practice, only because I don't know how else to do it. But it's just, and again, it's because I'm made to do these kinds of decisions. I'm, the healthcare system is so broken, and I really want to continue doing the work that I'm doing because I have such passion for it. And as I said, I'm finally happy again in medicine and in neurology, and I don't want to give it up. And there's only a few ways of which I don't have to give it up. And unfortunately, that means, cash pay and concierge kinds of services. And so that's what I'm thinking through actually right now about my next change of model.
Yeah. And I basically was in the same situation when I went to open my practice. I quickly realized, you do the math and you figure out, like you said, you can't pay for the Wi-Fi and a receptionist and, someone to clean the exam rooms and all of those, there's a lot of expenses. And even if you're, not part of a big hospital system, there's a lot of expenses. So yeah, it's really, really, really challenging.
It is challenging. And people also don't realize the extraneous expenses. I mean, I just renewed my California medical license for $1,200.
Right. Right.
I mean, and then there's all kinds of fees and malpractice insurance and, commercial insurance and there's all
EMRs.
Kinds of things. EMRs. Oh my gosh. Yeah. EMRs. Right. Exactly. So and I don't think that the public understands. I mean, we're nickeled and dimed as doctors. We really are. Yeah. And so it's very hard. It's a very hard profession to be in if you want to do it well for patients. So you have to make these hard decisions.
Yeah. And if you want to treat people that have chronic problems, because that's so different than dealing with a discrete, specific thing. Very, very different. Yeah. And speaking of things that are more, widespread, multisystemic, the role of connective tissue in health. Getting back to that, what has surprised you the most about the role of connective tissue?
What has surprised me the most is that without our connective tissue, we have no health. So what I learned that I never knew and was surprised to learn was that where our anatomy sits is genetically predetermined. And so if your connective tissue is failing to keep it where it needs to be, then nothing is going to work well. Now, we've always learned from physiology, of course, anatomy and physiology, remember those days? That a lot of our body works through cellular signaling. And so there's an expectation that where the signal is sent out from, that it'll be delivered at a certain place. But when that connective tissue isn't holding that organ and therefore those cells in the place of which, and even if it's off by a millimeter, it's not where it should be. And that signal, while it gets there still, because it's in their vicinity, it's not as loud and it's not as strong. And it doesn't provoke as much of a post-signaling kind of transmission, right? So where the membrane of the receptor on the membrane receives it, and then there's all kinds of membrane transformations, receptor transformations of the membrane, and then it goes into the cytoplasm, and there's a cell, there's different components that take place for the signaling process to get to the nuclei or to one of the extranuclei vesicles in the cell. And so all of that is somewhat suboptimal, because the connective tissue hasn't sort of kept that organ where it needs to be. And so that was a big learning concept for me. And I don't think I explained it even all that well, but that was a big learning concept for me. And so then everything fell from there, where I realized this is why it's such a multi-systemic, complex, phenotypic presentation. And so, and that's where I began. And I started to sort of figure out what do we need to do? And, there isn't a whole lot of options for connective tissue, to be honest with you. And I always, the holy grail question I always say is how do I regenerate your how do I fix your connective tissue? Because that's the problem. Mm-hmm. Right? It's not, the meninges are connective tissue. The outer vessel walls are connective tissue. Our fascia that holds our muscles are connective tissue. The neurium that covers the nerves are connective tissue. So it's the fascia that holds our organs in place in our abdomen and our pelvic cavities and even in our chest cavities are connective tissue. So how do I fix this connective tissue so that everything stays put?
Mm-hmm.
And so, and it's hard. There's no easy answer for it. And so I have dived into a lot of regenerative medicine kind of approaches like peptides and, I've been working with a company called Hope Biosciences that works under an FDA program called Right to Try to use stem cells because we know that stem cells can regenerate connective tissue, but unfortunately FDA isn't really clear on how they feel about it. But the FDA has this program Right to Try, of which Hope Biosciences tries to work under with these complex patients. And so I've been working with them, so I'm always trying to think of ways of just sort of regenerating connective tissue or at least healing it, right? So it's inflamed because mast cells are largely aligned within the connective tissue. And so if you have mast cell activation disorder, they are very easily triggered and degranulating, and so causing all this inflammation. So at the very least, I try to manage those mast cells so that I can reduce inflammation and therefore reduce the inflammatory burden on the connective tissue. And that will allow maybe for some natural healing of it. But with the patients with EDS, I mean, there's already an innate, probably genetic component of connective tissue disorder. So that's hard to overcome, but you can. And then, of course, every exposure results in some immune response and some inflammatory response. I mean, we even showed that COVID degrades connective tissue, and mast cells release, some proteases that target collagen. So what I'm saying is not theoretical. We know that this takes place. So if somehow we can manage this and counteract it, I think that we're giving the connective tissue at least a fighting chance.
And what peptides do you tend to recommend most commonly?
My favorite is thymosin alpha-1. It's a great immunomodulator. My other favorite is GHK, which actually is used in burn centers because it helps to reduce scar tissue formation, but also helps to lay down collagen layers in a little bit more of an architecturally sound manner. So it's a little bit more structurally sound. It's got more integrity to it. And so I put in the past 5 years, I've put almost all of my EDS patients on GHK. It's an injectable, but with little insulin needles, so you don't really feel it. It's like the GLP-1 needles, actually. And so it really does help the connective tissue.
Very interesting. So would you prescribe both of those in the same patients? Would they sometimes take both, or would you try one?
Both. You can definitely do both. I mean, sometimes because they're out of pocket, of course, as everything is, because nothing is covered by insurance that actually works.
Right.
So that's not true. I mean, some of the medications can work, and they're covered by insurance. But
a lot of things are not.
A lot of things are not, correct. Yeah. And so because of that reason, maybe sometimes I'll just say, let's start with one. And I usually start with the thymosin alpha just because I want to get some immune system control going, because like I said, there's a constant immune provocation that happens. But then I'll quickly add the GHK, and sometimes, patients will be able to afford both at the same time. I mean, they're not super expensive, though. For some, it's like I would say like $200 a month for each, maybe closer to $300 for one of them. But so not like crazy expensive, but obviously not affordable for everyone.
Yeah, definitely not. And is that something that you need to keep taking, or that you could take for a little while and then stop?
Yeah, so I do what I refer to as receptor rest, and I think other people have sort of stolen that phrase, but because at some point I think the receptors just get saturated, and so you're just wasting your money because it's got nowhere to go. But so I generally do it for 3 months on, and then 1 month off, and 3 months on, 1 month off. But I made that up, to be honest. I mean, not the receptor rest part. I made that frequency up. So that's where art over science comes in, right? And I do a lot of art over science, to be honest with you, in terms of like my recommendations and even the frequency of which I recommend certain things. And because there isn't a whole lot of evidence to go off of to really do evidence based on these kinds of options for patients who have been suffering for decades in some cases. So I just always say things like, I believe this to be true because I've just been doing this for years and I've seen so many patients. So and I know it's not going to be harmful. So I still honor my oath, Hippocrates' oath, right? Is that it's called Hippocrates?
Yep.
I first do no harm. And I at least think that there's the potential for a beneficial yield. And so that's when I will recommend it and then come up with 3 months on, 1 month off kind of thing. So.
Yeah, no, that's super interesting. I personally have not tried either of those. I did try BPC 157 a number of years ago. My husband and I actually both did that. We would inject it on each other, every night.
Oh, that's so cute.
Isn't that romantic? He's coming up a lot this episode. Is that?
Well, it's almost Valentine's Day, so
That's
apropos.
true. That's true. Happy Valentine's Day, honey. Is that something that you sometimes recommend, or not
Yeah,
usually?
I mean, I like BPC. I mean, yeah, so thymosin alpha and GHK are my top two. I would say my third is BPC 157. So
Okay.
yeah, I like that one a lot.
Okay, sounds good. We had quite a few questions from the listeners, and for those who are listening to this episode who also submitted questions and listened to episode 90, I promise I'm going to try to get through as many of these as possible, Dr. Ruhoy, but we're going to need to wrap up soon, so we probably won't get through all of them. But I will save them for our next conversation when we're going to talk about plasmology and other topics that we haven't covered yet. So I want to try to get through some of these though. And so like one that I thought was great, and you kind of alluded to this a little bit at the beginning, is it better to lean into cognitive dysfunction or fight against it in the moment?
I'm not exactly sure what that means.
I'm not sure either.
Meaning, okay. Fight against it. How would you fight against it, I guess?
I think maybe they're referring to like kind of pushing through versus like what you said about going into a dark space and kind of taking a little bit of a rest.
If that's your brain telling you it needs a rest. And so, the brain is the most metabolically active organ of the body, right? So remember that. And if it's not getting what it needs, it wants to shut down because it cannot generate the kind of energy that it needs to function appropriately. And it does not like that. Your your entire body wants to be well. That's the beauty of resiliency of the human body. It really wants to be well. And so you have to listen to your body and most importantly, listen to your brain. So if you're having difficulties with cognition or with processing speed or latency of response, which is a very common thing I see on exam when patients are describing brain fog, meaning I'll ask them a question and you can see their wheels turning before they respond, and so then it's your brain telling you that it just needs a break. And that I see with a lot of my TBI patients and post-concussion patients. And frankly, I think long COVID ME/CFS, it's likened to a post-concussion syndrome. And I feel like that's an infectious kind of trauma to the brain, right? So it's not a physical trauma, but it's an infectious trauma. I mean, there is chemical trauma. I mean, I have a lot of patients with chemical traumas from certain medications. I mean, fluoroquinolone is a perfect example, a lot of fluoroquinolone toxicities, but also there are some other classes of drugs that can create some trauma to the brain. So I'm sort of rambling now, but I guess the answer to your question is listen to your brain, take a rest, don't fight through it.
So I will tell you, your rambling is always beneficial. Your rambling is always so educational. And fluoroquinolones, we know, are toxic to connective tissue. And I literally remember one night, this was many, many years ago, I was very, very sick, and my PCP had ordered levofloxacin for me for this infection. And I literally remember in the middle of the night thinking, wait, if this can cause tendon rupture, then what's happening before the tendon rupture? Like
exactly.
That's exactly right. Yeah, if only a small number of people are getting tendon rupture, what about the other people that are maybe getting? And this was I was at an anesthesia conference at the time, and had to be at least 15 years ago, maybe 20. But anyway, so that's interesting. I didn't know that about fluoroquinolones though in the brain.
Yes. Yeah, absolutely. And so it's funny that because I have a similar story during that whole time when no one was taking me seriously and people would not listen to me. And someone told me that I asked for an MRI, but they did a CT scan of my sinuses. And because I said I had headaches. And so they were thinking, well, maybe it's a sinus problem, even though I've never had sinus issues in my life. Anyway, so they took a CT scan and they said, oh, you have inflammation of your sinuses. I looked at it, there was no inflammation. But regardless, they prescribed me moxifloxacin. And I said, for what? And they said, for your sinus infection. I said, I don't see any sinus infection and I have no sinus symptoms. What are you doing? And they said, just take the moxifloxacin. And I was desperate. I mean, like these patients are, right? I was not feeling well and I was only getting worse. So I took the moxifloxacin and I was so sick, Linda. I was so sick. So I would take it. And then within 2 hours, I had a high fever. I was nauseous. I was dizzy. I developed rashes that would by the next day be gone. And so I was like, I thought, was it really the medication? And I would repeat it. And I did it 3 days in a row and it was the exact same response. I called the nursing line. They said, it can't be the moxifloxacin.
Oh, that just drives me crazy. I'm sure you hear this from people all the time when they're told that's not possible.
Yeah. Oh.
And it's like, oh my, what? Because really, you know everything that's possible.
Right. That's such a good point. And I always say to patients when they tell me about a side effect, I say things like, well, that is a little atypical for that drug, but I'm always willing to believe that anybody could react in any way to anything, right? Because we don't understand their bodies or the state of which their bodies are in terms of like an inflammatory state or an immune dysregulated state. I mean, we don't know. I mean, the immune system and the autonomic nervous system, it's so complex. And to act like everything is POTS, for example. I told you, I'm very sacrilegious today. Like it's so complex. Like I don't think any one of us can pretend that we absolutely know the answer. I never think I absolutely know the answer. At least hopefully I don't pretend like I do. But anyway, yeah, I'm rambling in.
No, this is great. This is great. Stimulants. So that's something that, of course, a lot of people have tried for various different cognitive problems or ADHD, et cetera. Why do you think that oftentimes they're not helpful?
So what's so interesting about stimulants is that there's this biology group out in Drexel University. Shout out to them. And I wish I remembered their names right now, but I don't. That they actually did a study not in humans, but on stimulants and connective tissue. And they found that it was bad for connective tissue. And they reached out to me because
Really?
They didn't even know my daughter attends there.
Oh.
And that's what I thought. When I got the email, I was like, oh, they must know that my daughter's there.
Right.
Like, she's not in the biology program, but I didn't know. It's a large school. So I didn't know how they would know. But they had no idea. They knew that I was considered an expert in EDS, which again, always sounds funny to me as a neurologist. So they reached out and they said that they had done this study or they were proposing this study on rodents, I think. I have to pull out the email, but because they had done all this research that suggested that stimulant class of medications can be detrimental to connective tissue. And I was so intrigued by this. And then I thought about all my patients that are on stimulants.
Yeah, so that's fascinating.
I think the answer lies in there somewhere. And clearly we haven't elucidated this enough for me to answer it more definitively. But I think that stimulants have to be used in the appropriate setting. And I don't think they're always used in the appropriate setting. And I think some of the diagnoses for which they're used for which they're known to be effective for, I think have other physiologic and biological basis for that diagnosis in our patient population than what is classic to respond to the stimulant class of medications. Does that make sense?
Yeah, that does make sense. And I think the other challenge is a lot of times, at least I've seen this with my patients, that, they've been on something long enough and they say, oh, no, that doesn't contribute to my tachycardia. Or, once you're on them, I think it's really hard to be willing to try going off. And I understand because that's scary. And deprescribing is not something that we're taught, right? We're taught how to prescribe. We're not really taught how to wean off medications. I know. Or,
Isn't that interesting?
Yeah, it's very, very interesting. I had this conversation with our colleague, Dr. Heather Tick. It was super interesting. Well, actually, she's in Washington State also.
Oh.
So yeah.
She and I should get together.
Yeah, absolutely. And she does integrative medicine. I can introduce you offline sometime. But anyway, so I just think that it can be really, really difficult once you start something then to try going without it, because it might seem like it's helping. And some of the, like you said, if there's a detrimental effect on the connective tissue, you're probably not actually able to see that or appreciate it at the time. So that's really fascinating.
Yeah, I agree.
Yeah.
I think there's a lot of drugs that, sometimes work and sometimes don't. And I think that to learn why they work and why they don't would help give us lots of clues into caring for these patients. And, I often regularly say, I don't prescribe medication that I don't understand its mechanism of action. And so this way, if a patient tells me that it was helpful, then I have insight into what can be helpful or what might be the underlying pathophysiology. And then conversely, if it causes side effects, I can think about how that might have happened. And in terms of maybe things that I want to stay away from in the future with regards to other recommendations for medications. So I think it can be very helpful to understand the whys and the why nots of every medication that we use in our patient population. But that obviously takes a lot of time and effort and documentation. And so I think that's something that I I definitely need more time to write up a lot of what I do and see and think and say. But who has time?
And that's another process that I feel like your average person doesn't, really have a good comprehension of, and it's understandable why they wouldn't. But the amount of work that goes into publishing a paper, and it's a perfect lead into the paper that you published yesterday, which I was so excited to see about your practice and Dr. Bolognese surgical patients and the breakdown by different condition and looking at I think you call it upset for in terms of how you looked at the data and what overlapping conditions were present. Were there certain things this will be the last thing before we wrap up. Were there certain things in that study that came as a particular surprise to you?
To me, no, because, I do the clinical work. I've been seeing these patients for a really long time. I think to Dr. Bolognese, because he's just been the surgeon correcting their CCI, right? So, but I was the one caring for these patients up until that surgery. So I already knew that this cohort had a lot of these diagnoses that I had made, or others, other doctors had made, and then they just came to me for further care. But so I wasn't surprised by the findings. And, and I also followed these patients postoperatively. So I knew how well they were doing. And so for the most part, and that's why we just decided that we had to write this paper. And so we designed the survey and we sent it out and we got a lot of information, and, we were all very pleasantly surprised by the ultimate analysis. And so, it's been well received, actually.
Yeah, really, really fantastic paper. And one thing that really stood out to me was when you talked about the affected and unaffected group, and I thought that was a great way to put it because, well, I guess the affected group has a known diagnosis of a connective tissue disorder, right? And the unaffected group does not have a known diagnosis, but we know they still may have a connective tissue disorder.
Absolutely.
But the unaffected group, the technically listed as unaffected group, had a higher rate of having Chiari-1 malformation and also had higher rates of MALS, or median arcuate ligament syndrome. That was really fascinating to me.
Well, when you think about the role of the connective tissue, again, it does make sense, right? So in fact, Millerat many years ago found that those with hypermobility actually were at greater risk of Chiari malformation. So that had been shown previously. But I agree with in terms of the compression syndrome, like MALS, it's a connective tissue disorder. It's a ligament, right? So it made sense, of course. And it just sort of drives home the importance of evaluating for all of these diagnoses for these patients, because, technically and theoretically, you should need them all corrected for the patient to really have a chance at full recovery. So that's what we do. And we look at every single one of these diagnoses for patients and try to make sure that we've at least identified it, addressed it, managed it, did what we need to do for it. And patients do well when we make sure that we've comprehensively covered all of it.
Yeah, that's really important, because we know that so many people are experiencing so many different things. And that's why when they go to a doctor who only has 5 minutes, it does sound like they're making some of this up, because we're not taught in medical school that you can have that many things wrong with you simultaneously.
That's right. Right. It's so true. It's like you have to have one thing. What's your chief concern, your chief complaint?
Right. Yeah. Okay. Well, this has been such a fantastic conversation, and we end every episode with a hypermobility hack. You've given us already, of course, so many great hacks, from the peptides to different medications that you prescribe and things like that, and different therapies with the IVIG and plasmapheresis and things like that. But do you have any additional hypermobility hack that you can share with the listeners?
Additional. That's hard, because I did give a lot of my usual stuff, but I think that honestly, I always tell patients that a really good physical therapist that understands a hypermobile body is like worth their weight in gold, in my opinion. Because, all the fancy surgeries and the medications that we can prescribe, and even all of the peptides that I do, and plasmapheresis and immunotherapies, you need a good physical therapy. Nothing is going to correct the underlying hypermobility permanently. We can reduce the burden, we can improve the integrity, but a good physical therapist who understands a hypermobile body really is the cornerstone of therapy for forevermore, frankly, right? So well into later in life, to keep the joints flexible, to keep them moving, to keep things aligned and symmetric as best as they can, though none of us are symmetric, but as best as you can to sort of keep it symmetric, and just to really be your friend throughout this journey in life as a hypermobile body.
Mm-hmm. And I'm glad you mentioned flexible too, because I feel like so many people stop stretching completely. And of course you want to do it the right way, but that's what I did. And now I have parts of my body that are so incredibly inflexible. And that's not good either. I mean, we want to be doing it in a very thoughtful and careful way, and like nerve flossing and things like that. That can be
You were a dancer.
Oh my gosh, I was so flexible. I mean, we would do this thing called heel in the hand. And so you'd wrap your arm all the way around your foot, and you'd put your leg like this, and you just, no problem. And obviously doing the splits every which way and stuff like that. But now I'm so not flexible. And because I was having so many problems when I had my Tarlov cyst, and before I had my Tarlov cyst surgery, and I had so much pain in my hamstrings, and I was basically told, don't stretch. And I kept, because it hurt in my brain, I'm thinking this is, danger, danger, right? I'm getting that message to my brain. So I didn't stretch my hamstrings for so long that now it's, that part of my body, my posterior chain anyways, is very stiff, which is not good. Yeah.
No, it's not good. But you should work on that with a good physical therapist.
Yeah. I do have one that I see regularly. In fact, she was on the show recently. But I'm continuing to work on it. And I probably should investigate maybe adding some other thing. I do red light therapy also.
I love red light therapy. So the COX enzyme of the electron transport chain is a photoreceptor. So it's very responsive to things like red light therapy, and it helps the mitochondrial function. So
wonderful. Do you have a favorite red light device?
I do, but it's like $150,000.
Oh,
I don't own it. Don't get me wrong. I don't have that kind of money. But it really is like, when you look at the parameters and sort of how it works and the technology itself, like, it's really amazing. I'll send you the link. You can buy it.
Yeah.
And then I'll come to you and use it.
Yeah. No problem. I just got a spare $150K in my back pocket. And there are places where you can go.
Yeah.
And there's also things that you can purchase. So are you aware of what the difference? Of course, it probably depends on the place and the thing that you buy. But since you mentioned this one that's like, obviously out of most everyone's budget.
I don't support any. I mean, I don't want to name brands because I don't support brands, and but I do think that there are low quality ones and high quality ones,
right?
And so I often wonder, like, if it's even worth a few $100s for a low quality one that a lot of my patients are buying off the internet, and But I know that red light therapy as a treatment plan, as a modality, can be very effective.
Mm-hmm. Okay, wonderful. Before we go. First of all, I want to thank you so much for joining me again. So this is actually technically the third time that I've interviewed you, which is such a treat. I'm so fortunate to have been able to. I love talking to you. Yeah, I always love talking to you. And I will make sure to link all of those other episodes in the show notes so people can listen to those as well. And I also want to hear what projects you're up to, if you have any new research projects or anything like that.
Yes. So I'm a couple of projects. I mean, I'm doing a muscle biopsy study for electron transport chain abnormalities in ME/CFS and long COVID patients. And so that's sort of exciting for me. I think I had mentioned that maybe in a previous episode, but so that's one of the projects that I have going on. But I'm also working on like a masterclass kind of thing, like an educational. A couple of people had approached me to do this, and so I'm excited to do that, to do a masterclass on basically neuro-EDS kind of thing. And then I'm also writing a paper on neuro-EDS, so it sort of goes hand in hand. And I think that's it, actually. So otherwise, I'm working.
Yeah. No, you're very busy. You're very, very busy. And for the course, who is the intended audience for that?
Patients. Yeah.
Okay.
I mean, obviously, I would love doctors too. I mean, so David and I, Dr. Kaufman and I, have a podcast. I think it's called Unraveled: Understanding Complex Illness. We recently went to YouTube. We were on Patreon. And so our goal, of course, was to educate. And we had hoped to get a lot more physicians as subscribers when we were on Patreon. We do have a few, but not as many as we'd hoped. We have a lot of patients and who are supporters, of which we love and are grateful for. But our goal is to actually help patients by educating doctors, right? So that patients are better understood. And so we moved to YouTube in hopes that we could improve the number of physicians that are subscribing, I guess it's called on YouTube, subscribing, not prescribing. So we just moved there. And so it's fairly new. And we actually do have quite a few more subscribers than we did it on Patreon. So hopefully we're keeping our fingers crossed. And I think that we're going to be on your podcast together sometime in the future.
Yes. Wonderful. That's so great. And actually we did a pretty big survey recently and found that 20% of the listeners of this podcast, at least in this survey, are healthcare professionals.
Oh, wow. That's a great number you have.
Yeah. It's
fantastic.
Really great.
Good for you.
Yeah. It's really great. So while I agree, I love educating patients, and that's so important. We know that if you can educate a physician and raise their awareness about these conditions, and they can provide better quality of care. And there are of course some really great programs out there like the EDS Echo program, but most physicians are so busy, they're not going to take the time to, take that much time out of their schedule to learn about something that in their mind, at least when they start it, doesn't affect that many people, that many of their patients. Yeah.
Right. No, and I think it's like that old saying, if you give a man a fish, he eats for a day. If you teach him to fish, he eats for a lifetime. And so it's similar in that we want to help patients by educating doctors so that when patients go see that doctor has a better understanding of what might be going on and where he or she can start. Right. So that's our goal.
Yeah. And hopefully they won't be gaslighting people anymore and be much more empathetic and everything. Even if they're within the insurance system and they can't take a lot of time, maybe they can have them come back for another visit and things like that.
Exactly.
So,
yeah. It could be done in several visits.
Right. Where can we find you online?
I have a very mediocre social media presence. So my new practice is called anthurium.org. So it's a plant. It's a perennial plant that has a heart-shaped flower. So it's a very pretty plant that always sort of resonated with me. So it's called Anthurium, ANTHURIUM.org.
Okay.
So they can see my practice there. And then I'm on Bluestein. And I don't remember the name of my handle. It's a weird, long social Bluestein, but it's Ruhoy.
What's Bluestein? I'm not.
Oh, it's the new. So when people left Twitter, they went to Bluestein. Somebody told me to join Bluestein, so I did.
Okay.
And I'm also still on Twitter. It's at Ruhoy MD, and then I'm on Instagram. So which I actually sort of like, but so Instagram is Ilene Ruhoy MD PhD, and then I have a TikTok account. I know it's almost embarrassing. Like I'm 100 years old. What am I doing? But it's fun. I actually enjoy it, and sometimes people will ask me questions, and I love to educate. Like it's a passion of mine. I just really love educating. Anyway, so I have a TikTok account, Ilene Ruhoy MD PhD. So that's where you can find me. So come follow me everywhere, because otherwise I'm really considering leaving these accounts. If it wasn't, to be honest with you, if it wasn't for the book coming out, and my publisher really wants me to use those accounts because I do have followers. So I probably would consider, because my public persona, I'm always uncomfortable with. I always feel like, oh, that's so cringe.
Yeah. It's hard. It's hard because we're not, we both went to medical school and through residency and everything because we wanted to take care of patients, not to be, TikTok famous or anything like that.
No, that's exactly right. It's funny because I will post a video and then I won't look at it for weeks because I won't want to know what people are saying or how many likes it got. I'm very weird about social media. So go follow me so that I think that it's worth it.
Yeah, absolutely. We will make sure to link all of that in the show notes so people can find your website and your YouTube channel and all of those other wonderful places. Because you're right, it's a lot of work, and
it is a lot of work.
It's wonderful to hear nice things from people, because that's the other thing is we're human too, right? And so I don't know if this ever happens to you, but sometimes I'll get 20 wonderful nice things and then one thing that's not as nice, and I find myself hyper focusing on that one, and totally. It's bad because there were all these other wonderful people that said such nice things and appreciate the work that we do that does not bring in money and or cost money for us to do. It's like this podcast is free to the listener, but is a labor of love for sure.
Yeah.
So.
Yeah, no,
Right.
that absolutely happens to me, which is why I don't look at my post for weeks at a time, because I don't want to see someone who might have not loved my video or my post, because then I am very sensitive in that regard.
Yeah. Oh, I'm glad it's not just me. Oh my goodness. Well, I just love chatting with you. This is so great. I think I should have to schedule more podcast interviews with you just so we can hang out. And of course, everyone's going to love hearing anything that you have to talk about. So thank you so much. I know that you are crazy busy. You've got a lot of things going on, and we'll definitely have to have you back when the book is out so we can talk about the book more specifically.
I would love that. Yeah, for sure. Yeah, so that people can read it first and then sort of know what it's about, and I could talk more specifically about it. But and we'll plan that episode to answer more listener questions, because I do feel badly that we ran out of time to address too many of the listener questions that came in last time. But I also want to be respectful of your time. I appreciate that. I do have a transcranial Doppler to do right now for my patient.
Oh, I really need to let you go then. Yeah.
But I love answering listeners' questions. And in fact, David knows that I get very upset during our live sessions when we can't cover all of the questions that come in.
Sure.
So I really do want your listeners to know that the next time you'll have me on, if you'll have me, I will answer all the questions.
Okay. So we'll make that episode really just a Q&A, AMA kind of a thing. So well, thank you again so very much. It was so great to chat with you, and I really appreciate you taking the time. Yeah.
No, of course. Thanks for inviting me. And it was great talking to you.
Well, that was so much fun talking with my very dear friend and colleague, Dr. Ilene Ruhoy, and I hope you enjoyed that as much as I did. Thank you so much for listening to this week's episode of the Bendy Bodies with Hypermobility MD podcast. You can really help us spread the word about joint hypermobility and related conditions by leaving a review and sharing the podcast. This really helps support the show. If you'd like to meet with me one-on-one, you can check out the available options on the services page of my website at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, and LinkedIn at hypermobilitymd. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can find full video episodes up every week on YouTube at Bendy Bodies Podcast. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.